Hello, and thank you for joining the Systems for Action RESPROG webinar. My name is Chris Lytle, and I'm Deputy Director of Systems for Action. For those who are new to Systems for Action, we're a signature research program of the Robert Wood Johnson Foundation, based in Denver at Colorado School of Public Health. We support studies across the country, testing mechanisms intended to align and connect medical, social, and public health systems with the goal of improving population health and advancing health equity. Our RESPROG webinar series serves as a platform for S4A investigators to share findings at various stages of their studies. Today's presenters recently completed a 2-year study which tested an integrated delivery and financing system for older adults with health and social needs. So a little bit about our agenda for the day. We'll hear from our presenters, Dr. Jose Pagan and Lisa Fisher. Jose is from New York University and Lisa is at New York Academy of Medicine. Before we'll hear commentary from Annie Wells of Lifespan of Greater Rochester. Throughout their presentation and commentary, please feel free to ask any questions in the Q&A box at the bottom of your screen. At the end of the commentary, we'll have about 10 minutes or so to have our presenters answer your questions. So now a little bit more about our presenters for today. Dr. Jose Pagan is chair and professor of the Department of Public Health Policy and Management at NYU. He is also director of the Center for Health Innovation at the New York Academy of Medicine, an adjunct senior fellow and member of the Executive Advisory Board of the Leonard Davis Institute of Health Economics at the University of Pennsylvania. Lisa Fisher is the Deputy Director of Population Health and Health Reform in the Center of Health Policy and Programs. Her work at the Academy focuses on research and evaluation related to state and health reform and community-based initiatives that promote health equity by increasing access to quality health care and addressing the broader determinants of health. Annie Wells, who will be commentating at the end, is the Director of Care Transition at Lifespan of Greater Rochester. She has 30 years of experience in the field of aging and disability and oversees the healthcare initiatives and program development at Lifespan aimed at reducing hospital readmissions and emergency room use. So with that, I will pass the mic over to the presenters.
Thank you, Chris. What I'll do is we're going to tell you a little bit about how the program was structured, what were the main findings from the evaluation, the project team, and so on. But one of the most interesting parts of the conversation today is about what happens with all this research and sort of like how the funding from RWJ has been leveraged by Lifespan to basically work with healthcare systems, payers, and others interested in their very interesting model of integration of social services and healthcare services. So let me get started with that then. So the project team includes Lisa Fisher at the New York Academy of Medicine. This project actually got started when right at the time when I was actually before NYU at the New York Academy of Medicine. I have a PhD student, Kelly Akiya, working with us. We also have Yan Lee, who's a biomedical engineer that he's helping us with thinking about how the data and results from our study can be incorporated into decision models that can help anybody that wants to implement a program like this, implement it and look at cost and healthcare utilization and sort of like what are the type of services that could be mixed together in a program like that. And then on the Lifespan side, we had Annie Wells and Christine Peck. And you'll hear from Annie in a few minutes. And a key partner in all of this was the Rochester Regional Health Information Organization, Wendy Beener and Andrea Richardson. They have been critical because although Lifespan has a lot of data connected to social services and its integration on the healthcare delivery side, they don't have they don't have the visibility of that the Rochester has in terms Rochester Rio has in terms of hospitalizations and ED visits. So the role was critical in getting this project done. So the first thing is, what does Lifespan does? Lifespan basically, I mean, this sentence summarizes that helps older adults and caregivers take on the challenges and opportunities of longer life. So basically, they provide a mix of services or link individuals in the community, older adults, with a set of services that can help them lead a better life. So, and these services can range from care coordination to meals to financial assistance to somebody that is going to come visit you at home and so on. And the critical services in any community. And with everything that is going on now, it's I am sure that they're in high demand because they're an important link to people that are isolated now. So that's a conversation that actually I'm sure many people are asking Lifespan about the role in all of that. So the Community Care Connections program it is a program that helps older adults remain in their own homes. That's their main goal. The measures that are used is basically, the goal is to reduce hospital admissions or readmissions and emergency department use. And they also have programs and activities to reduce caregiver burden. And this integration, even though typically a healthcare provider, for example, could make a referral to an agency like Lifespan, what Lifespan did with the Community Care Connections program was to do it in a more integrated way with the healthcare delivery system. So use the healthcare system to connect clients with Lifespan in a very, I'm going to use the term specific or systematic way, using social workers, nurses, community health workers to then identify and address this full range of social and health needs of clients. And the way the program works basically is that patients are referred to the program by the primary care provider, and then a social worker, case manager, conducts a home assessment. That home assessment is actually critically important, because even though a provider may identify a need, for example, somebody is having difficulty with their medication management or not having access to transportation, you may be able to see other signs that something is going wrong, or there are additional needs when you do that home assessment. And then what the social worker do is then it basically connects the client with all the caregiver need and the caregivers with the social needs and the health care coordination that the person needs. So I gave you examples of what Lifespan is able to provide through Community Care Connections. Many of them are critical when it comes to reducing hospitalizations and ED visits, medication reconciliation, healthcare advocacy, communication with family and healthcare providers. And when we looked at the evaluation of the program, then even though each person that joins the program or that is managed by Lifespan, they have different needs. We looked at it as like, did you participate or not? But if we had more time to go through their data, we could actually analyze the data to the point of and look at the heterogeneity of the services that were provided and exactly for which patients it works and so on. And we did a lot of that, but there's still more work that could be done with that, given the richness of the data that is available to study how this program works. I know a lot of organizations want to do this. I've only seen a few that have the level of data that Lifespan has. So I'll focus on this, on the Systems for Action research project and the evaluation that we did. And it was pretty simple. How does the program impact patient well-being and system alignment? We wanted to know not only patient well-being, but when we say patient well-being, we also mean hospitalizations and ED visits. We want to know that. We also wanted to know something about how all these different players in this ecosystem work with each other. So for example, does the program give an opportunity to a healthcare provider to learn more about what Lifespan does? Does Lifespan learns more about how healthcare providers operate? Is the constellation of services that Lifespan provides or connects to, are they able to know more from each other? And later on, we also and Annie will talk about that, we've been able to communicate or work with payers and other folks in the community, and all of these sort of like activities across people in the system happen because of funding like this grant from RWJ. So to make this integration work, healthcare delivery, social services, it works because we do research, we have the data, and we also have even payers involved that are willing to look at our data and continue expanding or building on components that's basically work on projects like this. So we did it. The first approach was basically to analyze pre-post changes in hospitalizations and ED visits, and we wanted to do that using propensity score matching. We had looked at data before at the New York Academy of Medicine from Lifespan, but we only had data on before and after for the Lifespan participants. And the question that always came up was like, okay, you're telling me that if I have a person that joins this program, hospitalizations go down by 20-30%, depending on, say, the health condition. But do you have a control group? So that was actually the main point of doing the work through RWJ and the RWJ grant. And then we also did this by conducting interviews, to capture that part of the social, the system alignment components specifically, and getting more nuanced answers as to how a program like this works. We also had a component connected to analyzing the optimal mix of social services using system science. So we have a model that basically tells you how over time people can move from not being hospitalized to hospitalized or having an ED visit, and then how different components of the intervention could actually impact that, and we hope that could serve as a tool to help people make decisions like that. So let me then move on to how the project worked. Basically, when a client joins Community Care Connections, a caseworker is going to input information into a system. The system is called PeerPlace. And then that data, which has the name of each, it's identifiable data, gets sent to the RIO. The RIO then has access to all these data from hospitals in the Greater Rochester area. And what they do is they're able to identify, if Jose Pagan had 3 hospitalizations over the course of a year, they'll be able to tell Lifespan when they happen, the exact date, and so on, in real time. The plus of a system like that is that the data is timely. You basically know when somebody was hospitalized right away. And as long as you have most hospitals in your area, in a system like that, it works fine. The difficulty or gaps are going to be related to the richness of the data, so you don't know a whole lot about the health condition of the person, or because the data varies according to what a hospital is willing to provide the RIO. So that became a challenge actually through the project, because we were not able to consistently know, for example, the health condition for which somebody was hospitalized, and we're not able to include information like that in the matching process. But anyway, once the data has been connected, then it gets sent to the New York Academy of Medicine for analysis. So NIAM is able to see the identified data set with these two different data sets combined. So because we had that experience working with them with the RIO, using that, the RIO is a health information exchange, the health information exchange system for that region. Then we basically work with them to say, hey, can you help us build a control? I'm not going to call it a control group. I'm going to call it a control pool. And from that pool, we basically built a control group. So when I say a control pool, I mean the following. I mean that well, I'll tell you in a second. Let me show you how the time frame and so on this. So I'll do this part connected to hospitalizations and ED visits, and then my colleague Lisa Fisher will talk about the results from the qualitative side component of the study. So we had data. I think in the resources that we will provide to you, you'll be able to see some of the earlier results that we had connected to pre-post analysis. Again, we did that because we had difficulties accessing also control group data. Part of it had to do with the fact that organizations like the RIO get bombarded by people asking them for their data, and they had to make some changes in their systems. And of course, that happened in the middle of the project. When you think some things are going to go very smooth, they never do. But fortunately, we were able to actually end up getting all the data that we needed and completed the project. So what we did is we conducted one-to-one propensity score matching, and we looked at it at a time that the way we defined the time period of 90 days before and after program participation was based on the fact that although many programs may last a lot longer than 90 days, or if you connect someone to a given service, it may last much less than 90 days. We noticed that most cases were open and closed within about 90 to 120 days. So the idea was that even though the program may have an impact in a much longer time frame, the 90 days sounded like the right time in terms of like the sort of like the expected dose or median dose or whatever we want to call it took place. And the way that the matching happened is so we basically asked the RIO, hey, you have all these folks that have been hospitalized in the region. Let's come up with a way of creating that pool. That's what I was telling you about the pool earlier. And what they did is they said, okay, let's find every person that has been hospitalized in or for which we have data over the time frame that you're looking at, the data from 2016 to 2018, 2019, and let's put them into different groups by gender, race, ethnicity, and county. And then from each group, let's pick people that are, say, within 2 years, of your lifespan groups in these same buckets. So the idea then would be to have a large group of folks that we can potentially pull from to create a control group. And so what we did is we once we got the data from them, and it was something like, I don't know the exact number now, but it was like 50, 60,000 people, something like that. So what we did is the data doesn't have the exact date in which the well, it has the exact date, but I only have, I have the data identified by quarters. I know the quarters in which the hospitalizations took place. I don't know the exact date for the control group. So if we have 10 quarters of data, we have basically 9 quarters. Each person can contribute nine quarters of a before and after period. Basically what I'm saying is 2 quarters. Each person can contribute 2 quarters. So if you think about it, then each person can contribute 9 before and after control group periods. So we go from this data set that we have of 50, 60,000 people to a much larger pool of potential control group periods. And what we did then is, because we know the exact date in which somebody joined the program, we're able to then look at, let's say that somebody joined Lifespan, the program in, say, March 15th. Then we're able to compare that person with somebody, pick somebody from the control group that the first quarter of this year and the second quarter become the pre and post period. So we were able to match it as close as we could on the day 2. And those are the 2 quarters that we would have picked. So the end result is that we once you take into account the fact that for some people, we have to exclude them because we don't have post data or pre-data, or we may have missing data. We end up with about 1,004 community care connection members, and we match them to 1,004 RIO patients selected from all these matches. And to give you a sense of how the data looks like, this is actually more recent data. I mean, it includes the data in the study plus a few more than a few more people, because but the data is going to look about the same. And because this comes from more recent reports that we have worked on with Lifespan. But you can see that 36% of the sample are between 75 and 84. You can see that most participants are white, mostly women, and you can also get a sense of 73% are from Monroe County, and income levels, because most folks are retired and so on, they're going to be relatively low. So that gives you a sense of the demographic data on this. And then when it came to health conditions, and we were interested in this too, 50% of participants, for example, had hypertension, and a third had diabetes. What we wanted to do there is we wanted to also see if the program had an impact by health condition. And we tried to do that. If you also look at number of health conditions, you'll see that many of the participants have 1, 2, 3, 4, or 5 or more conditions. We were interested in that because we know from insurance data, for example, that basically as the number of health conditions doubles, the cost of care basically increases. It doubles every time that you increase a health condition, or about doubles, at least up to the data that I've seen is up to 4. So that became an important issue to also look into. And so then because I have the number of we have the number of hospitalizations. What you can see here is that hospitalizations go. This is the average number of hospitalizations, not a rate. So you would basically see that if you pick up those 1,004 people, the hospitalization rate before the program started was 0.1 or 0.101, and that goes down to 0.061. In the control group, it basically goes up just a little bit. This data doesn't include the pre-hospitalization. The hospitalization, the number of hospitalizations, the average number of hospitalizations before in the pre-period. I also have that data, and So basically what you'll see is that on the first column of numbers, the intervention and control groups, the hospitalization rate would be the same. And if you look at the data that way, you will see that remember that if I do that, then the matching group will be different. So the results will be different. So you basically goes down from like something like 0.10 to 0.08, 0.09. So you still have the same, not the same, but you still have a reduction, a larger reduction in the number of hospitalizations in the intervention group compared to the control group, if you do it that way. We've also done it for ED visits, and you also see a decrease in the number of hospitalizations in the control group that is more, in the intervention group that is more pronounced than in the control group. And we also looked at the data by looking at average rates of hospitalizations by health condition, and also for ED visits. And there, although you see the same type of trend of, in general, of hospitalizations going down in the intervention group, and then moving all over the place in the control group, comparison group, you basically, the only key one that comes up there is ED visits for hypertension. So for ED visits for hypertension, you see a large drop in ED visits for the intervention group, but not as much for the comparison group. So so what I'll say at the end on this is, though, that I wish we had data on the precise health conditions that people had, that participants had, so that we could have used that as a matching variable. Having said that, I didn't show it to you, but the matches, they look very close, although it is very hard to know if they would have been matched with on the health conditions side. And it would have been also interesting to well, it would have been interesting to do a closer match on this. So okay, so Lisa, do you want to go next on the qualitative findings?
Sure. Thank you. So I'll talk about some of the qualitative work that we've been doing with this project. You can see here that we conducted 28 key informant interviews by phone with a variety of different stakeholders who participated in this project. We spoke with healthcare providers like nurse care managers and physicians. We spoke with Lifespan staff who were part of the CCC program. We spoke with CCC clients and caregivers, and we spoke with social service providers who partner with the CCC program. And for each of these groups, we adapted our questions for each group, but we did cover similar themes across groups, like perception of program impact at the individual, provider, and system levels, successes and challenges of the programs, barriers and facilitators to implementation, and things like that, so that it would allow us to look at themes across the different groups. Next slide. So here's a quick diagram we put together about our qualitative methodology. Basically, we collected data via phone, recorded phone interviews and had them professionally transcribed, and then used pretty standard qualitative techniques to analyze the data. So we had an iterative process of coding data according to both predetermined themes and also new themes that arose during data analysis. The process involved multiple members of the research team and a collaborative process for data interpretation. And then we did this both at the kind of stakeholder group level, so for example, by providers or by clients, and then also we looked across groups to understand system-wide impacts. Next slide. So this is just a diagram of how we analyze the data at various different levels, but it also goes to just illustrate the fact that we know that by impacting systems, we also impact providers and their patients or clients. And so, but just for the purposes of this presentation, and given that we're talking about a Systems for Action project, we'll focus on this systems piece and the findings there. Next slide. So here's just a summary of the impact of the CCC program at the systems level. You can see that that people in general felt like the CCC program led to a more efficient and less fragmented systems of care, a more holistic and individualized approach to care, improved communication across sectors, and improved access to necessary services, including both social services and medical care. Next slide. So now these slides will each go into each of those themes a little bit, and you can see they have a lot of text because we wanted to show a range of examples supporting each of the different themes. But for the sake of time, I'll just highlight kind of key pieces of some of these quotes. So in general, people felt that the program improved efficiency and offered a more streamlined approach to patient care, and as well as greater awareness of social services. Healthcare providers described the value that they saw in the fact that CCC offers them, one central place to call for support with social services, rather than, as this person says in the first quote here, being required to make multiple phone calls to multiple agencies and that kind of thing. And then the second quote is from a social service provider who explains that she's getting referrals now from providers far more than she used to, which she attributed to the relationship with the CCC program and how it led to increased awareness of the services that this social service person provides. And then we heard similar things on the healthcare provider's side, who said that they now had greater awareness of social services, and from Lifespan staff who talked about educating providers on social services, what existed and what limitations or challenges existed. And then last but certainly not least, clients also talked to us about learning about these new social services. In their mind, they were new, not necessarily that they didn't exist before, but that they didn't know about them. And so that now they were very grateful that they were aware and could take advantage of them. Next slide. So there was also a sense that the CCC program resulted in a more holistic approach to patient care. Lifespan staff frequently made the connection between the services they provided and health, saying things like, you can see in the third quote, that patients who have depression or anxiety, if we help them with benefits or have our financial management program help straighten out bill paying, the anxiety and depression certainly gets alleviated. So they made that connection very frequently. And then in the first quote, the healthcare provider explained that that kind of connection to social services, or that ability to address social needs, wasn't in their office before. So this healthcare provider explained that the CCC staff member is actually going to the home, working through some very important items with the client and his wife that in our office, we may have said, well, we don't really know what to do about your Social Security. And the clients sensed a difference also. They explained that they felt heard and understood, and noted that the CCC program helped them to find solutions to some of their most pressing challenges in their daily life, ranging from remembering doctor's appointments to reducing reliance on caregivers to accessing housekeeping or home health aid services. And although there were clients who weren't eligible for programs that they wanted or needed, the second quote on this slide is really consistent. Was a pretty consistent feeling among those clients we spoke with. And the client, who was a caregiver for her husband who had been frequently hospitalized, explained, the CCC staff member really listened to us. It was the first time that we had that from anyone after he came out of the hospital, and she really paid attention to what our needs were. Next slide. Oh, it looks like, okay. Sorry, so improved communications was a theme that came up often and was cited as a contributor to improved system alignment. Healthcare providers said that they regularly heard updates on patient cases from CCC case managers and care coordinators, and several said that they then enter that information into patients' charts and that it can then be used for care planning purposes. And that's kind of described in the first quote. And then the next quote, this staff member is explaining this CCC staff member is explaining how CCC really prioritizes closing that loop and keeping healthcare providers up to date on the status of clients' cases. And then also related to communication, but in a little bit of a different way, clients talked about how the CCC program helped them to more effectively communicate with their healthcare providers. Healthcare, we know, is difficult to navigate for anyone, but it's even more so for people who are older adults with many chronic conditions, who have a lot of appointments and doctors and instructions to navigate. And so clients really appreciated having one person who they could turn to, who could help them keep everything straight and communicate with their doctors. And that's what the client in the third quote is saying, talking about her care coordinator who attends appointments with her. She says, "She's more of a medical person than I am, so sometimes the doctors don't always explain it the way you need it. If I look like I'm confused, she will ask them, 'Can you explain it a little better?' Or she will explain it to me. I enjoy her coming with me." Next slide. And then, as one of the main goals of the program was to increase access to social services and medical care, we asked clients and providers specifically about that idea, and people talked a lot about that as one of the main benefits of the program. Folks explained, from their perspective, that the program increased access to services that mattered for health, ranging from access to transportation, to help with public benefits and grocery and meal delivery, to medication adherence, access to specialty care, elder abuse services, personal safety devices, the list goes on and on. And so the different groups we highlighted talked about different services, but they highlighted such a large range that it was clear that the program was really tailored to the individual needs of patients and clients. And so you can see the first quote talks about a client's health being better managed with access to greater specialty care that came through the CCC program. And then I'll just look at this last quote, or highlight this last quote from a client who said that Lifespan provided transportation for her husband to get to and from dialysis. And she said, "I think that's one of the biggest things that have made a difference in our lives. And then number two, they provided some services that we weren't aware we were eligible for, and that has helped a great deal also." So just kind of showing the combination of the two different kinds of support. Next slide. And then again, we wanted to focus on the systems piece of this, but we did look at themes that came up within the provider interviews and then also within the patient interviews. And you can see here that providers really appreciated having somewhere to turn to help their patients who they knew needed support around social and economic and environmental challenges, and knew that those things were impacting their health. They felt like with CCC, they were more confident their patients were getting the help they needed. They also talked about an appreciation for the time that they got back, that they weren't trying to spend, kind of, one person said, spinning their wheels, trying to understand what kinds of social services were out there and addressing certain issues. And so they felt like they had more time to focus on medical care rather than on trying to figure out social services, which really isn't their training. And then they also talked about having a better understanding of what patients were facing outside of their office that may be impacting their health. And just, they said things like, CCC is are the eyes and the ears in the home that I just don't have. And they talked about being able to adapt their treatment plans based on the understanding that they received from the CCC staff about the patient's needs. And the next slide. And then with regard to patients' perspectives and their caregivers, they talked a lot about the physical and mental health improvements as a result of participating in the program. They talked about improvements in physical health, like diabetes control, and things like anxiety and depression. They talked a lot about better access to primary and preventative care and better adherence to treatment recommendations. One of the big things that came out was this idea of social isolation and social support, which Jose mentioned earlier. But it really came out even before the COVID-19 crisis, that people saw their CCC case managers and healthcare coordinators as one person even said, like a family member that she could call. And so this quote on the bottom, speaking about her CCC case manager, she said, "She always calls here once in a while to check in on me and tell me if I need anything." They, let her know like that. And see, I like that because she makes me feel that somebody cares, you know what I mean? And so that was a common feeling among clients. And then last but not least, there was a lot of discussion around reductions in caregiver stress. So if it was a partner who was also an older adult, they talked a lot about being able to make it to their own appointments, or just the reduction in the worry and the stress that they felt daily. But other people who were clients who might have been in need of some caregiving, they also talked about how they appreciated the reduced burden on family members and children and things like that. So I know I brushed over those things pretty quickly, but the qualitative data that we collected has been really powerful and valuable. And I think, Annie, who will speak soon from the Lifespan perspective, will talk about a lot of the lessons learned and how they're working on sustainability. And so I'll skip through this to make sure she has time to talk. And this is just next steps that we're working on, expanding the program and the research, and more fully exploring qualitatively some sustainability opportunities and challenges. So I'll skip through and let Annie take over.
Thank you, Lisa.
Go ahead, Annie.
Yeah, thank you. So I'm been involved in the development of the project from the beginning. And I think you could go ahead and move to the next slide. So speaking from our perspective as a community-based organization, historically we saw older adults experiencing multiple ED visits and hospitalizations unnecessarily. And we were seeing a gap occurring, really between us and healthcare providers, that each of us didn't really know what the other was doing. And so I think, what this project and this study has helped us do was to learn how to truly integrate with medical systems of care. Initially, early on, we tested different access points, such as emergency rooms and emergency medical services providers, and we discovered that it really was most effective to coordinate care with the primary physician offices. And often we find that the RN care managers are frequent partners in coordinating care. It's not to say that we don't follow what happens when people are hospitalized. We receive alerts from RIO, so we know when people are hospitalized so that we can immediately act to help make sure that transition is successful when people are home. We visit them at home, within a day or so of discharge from the hospital. We learned that we needed to make the use of our intervention easy. So we've got a central point of referral. And as Lisa has mentioned, communication was really key. Some of the things that we do, on a practical and operational level is we share care plans. We participate in huddles and team meetings on a regular basis to keep that communication going, as well as the day-to-day communication between the social work care managers and the LPN healthcare coordinators in the physician's offices. So also, we learned what data is of most interest to funders and potential funders, both qualitative and quantitative. And then finally, I'll just mention on this slide that we really have learned a lot. We have a lot of tools and lessons that we've learned that we can pass on to other colleagues at other community-based organizations. We have done presentations locally and also statewide and even nationally. We've made presentations on how we've been successful with this integration. Next slide, please. Thank you. So we're on a path to move from demonstrations to a sustainable payment model. The study results really have helped us to obtain more funders and contracts. What we find is success builds on itself. So as we're able to present the positive results, both qualitative and quantitative, we've been able to interest foundations and accountable care organizations and also a local insurer in working with us to further develop the model. And hope what we're working and hoping to do is to roll these demonstration partnerships into a sustained payment model, including value-based payment agreements. And so that's where we're at today.
Running. So so we will go through questions now, and I see that there's some questions here. Annie, since you were discussing what's next, and there's some questions connected to the intervention itself. So what interventions were specific to social isolation, and how did you measure social isolation?
Okay. So specifically, what we found, particularly with people receiving the healthcare coordination intervention, is that people were more likely to attend their medical appointments if they knew that the LPN healthcare coordinator was going to be there to meet them at their appointment. You might have noticed in the data that almost half of the people in the study live alone. And so knowing that someone was going to be there really motivated them to be more involved in their healthcare, and helped them to see that someone was looking to help them increase their ability to self-manage their health. In addition, some of the things that we recognize as we screen people use a tool called the Geriatric Wellness Screen. And part of that screen identifies the person's social needs. So we may, for example, refer the person to a daytime program, a senior center. At Lifespan here, we have something called a multi-purpose aging resource center. That's kind of like a modern day senior center that's very focused on both physical health, exercise, but also emotional health. We refer people to counseling programs, and we have a geriatric addiction program. I could go on, but I know that we're limited on time, so I'll stop there.
Thank you, Annie. I'll ask you another question since you're at it. The question says, I noticed a small number of Black African-American, the Black African-American population. Is that a result of the number in the 65 plus pool, or are there challenges in engagement?
I think that the demographics fairly closely mirror what we see in the Rochester area. I do think there are always opportunities for us to increase our approach to diversity. But I think, you know, our understanding is that we're pretty much capturing the demographics as they present to us in the local area here.
So there's a question that, another question that, what were the statistically significant differences between the intervention and the control group? Were there statistical differences between the intervention and the control group? So when you look at, of course, the 500,000 plus the control pool with the intervention group, we were matching on age, ethnicity, race, gender, quarter, and we also had information on location where they lived and even pre-hospitalization. So the matching, once you do the matching, you know, the two groups look about the same. I mean, they very closely match. If there's so there's no differences between the two groups. If the question is connected to differences before and after, the answer is yes, especially for hospitalizations. For ED visits, I still have some work to do there on I mean, I think part of the challenge has to do with the fact that we don't have like the health profile of each person because of the type of data that we have available. But we're working on this to send it out to a paper. So I apologize that I didn't show you that the comparison between the two populations, and I only show you the demographics for the lifespan members. But it was more like I had it in data. We have it in tables that we're going to use for publication there. So let's see. So there are a couple of questions here. What are the best practices? What are the best practices for integration that can be duplicated in other areas? And what seems to work when establishing a model of integration that involves hospitals, the medical community, health plans?
Oh my goodness.
You need some organization that leads. For example, in this case, it's Lifespan, but they move quickly to build partnerships and so on. But you also need funding, right? You need funding and you need sustainable funding. So you need a combination of those two aspects to make it work. And that's basically the main issue to make Annie or Lisa, do you have any comments on that?
So I'm sorry, I didn't hear some of that. The audio, there was a little bit of difficulty with the audio, but in terms of integration with the healthcare systems, just, you know, one other thing maybe to mention is that it's really important to understand at the outset when you're beginning a partnership is to understand and agree what metrics are to be measured and how success will be defined. And, you know, we find that for different partners and payers that can be different. So it's really helpful to have those conversations right up front.
Thank you, Annie.
Mhm.
There's a question here connected to, will there be any additional information that we will look at, data to be analyzed and so on? How much longer will the data be analyzed, and will there be additional information that you will look at? We have tons of data that have been able to analyze. I mean, I think there's some nuances connected to the types of services that people receive, the health profiles that folks have that we haven't fully analyzed. I mean, we have analyzed, but it's not. But there's so much data that is, it's crazy. One thing that I've noticed is that even though we had good data on hospitalizations and ED visits, it's not like I told you, we didn't have like the complete data on health conditions. So when people look at the data, especially potential partners, they see it and they say, okay, I think we can augment that, for example, by looking at claims data, health insurance claims data. So the fact that we did this study has made people think about how it can be improved and how much other data pieces could be brought together to make a more to add to the story, basically. And I've noticed a lot of interest on that. So, okay, so I think that's it, Salina and Chris.
Thank you so much, Jose, and apologize to everyone for the sound snafu for a split second. But it was really interesting hearing the benefits of aligning medical and social services, especially in a way that is tailored to the individual needs of patients and is mutually beneficial to providers. So enjoyed this presentation immensely. So we'll wrap up with a few announcements in these last few minutes. If you would like to receive a certificate of completion for today's ResProc webinar, please complete the survey at the end of the session. We'll also be emailing you one for you to complete as well. And if you enjoyed this webinar, be on the lookout for our next one, May 27th at 12 p.m. Eastern. Mariana Chilton will discuss the impact of integrating behavioral health with temporary assistance for needy families to build a culture of health across 2 generations. And of course, Systems for Action is a national program office of the Robert Wood Johnson Foundation, the collaborative effort of the Colorado School of Public Health, administered by the University of Colorado Anschutz Medical Campus, Aurora, Colorado. Thank you again for joining us, and we look forward to talking to you again on May 27th. And the slides, along with the recording of this webinar, will be made available on our website, systemsforaction.org, where you can also discover our other projects and listen to their research in progress webinars along with any publications that they have. Thank you and enjoy the rest of your day.